All right, good morning, everyone. We want to settle in. So thank you guys so much for joining us for UNC's 12th Annual Business of Health Conference. We are so excited to be finally back in person with you guys. My name is Stefania Zhang, and I am one of the Healthcare Conferences VP, and I'm joined today by my co-VP, Chitra. We had the pleasure of working with UNC Center for the Business of Health on behalf of the MBA Healthcare Club to organize today's conference. I want to also thank you, my liaisons, Yuki Yokoda and Andrew Yang, and all of the volunteers today that came to help out for the conference. And with that, I'm going to hand it off.
All right, my name is Chitra Sravanan. I am the other co-healthcare conference VP with the MBA Healthcare Club here today. Thank you all so much for joining us. We're so excited to have you back in person for our first in-person conference since 2019. So this year, the theme of our conference is the role of innovation in value-based health. So our speakers and panelists throughout the day will be discussing and exploring the role of innovation and how the healthcare industry is moving towards value and how innovation plays a role in that and sometimes also helps and hinders it.
We're very excited for all the diverse perspectives we've gathered here today. We hope you walk away today with new insights, new ideas, and new questions, and we hope you take full advantage of just making new connections with your peers and the industry leaders here today.
With that, we'd like to officially welcome you all to the conference and kick this off. So now I'd like to introduce Brad Statz, Faculty Director for the Center for the Business of Health and Senior Associate Dean for Strategy and Academics and the Ellison Distinguished Professor of Operations here at UNC Kenan-Flagler.
Awesome. Thanks, y'all. Stefania, Chitra, thanks so much for getting to this day, along with our healthcare club as a whole. Tremendous amount of work goes to get us here. Also recognize our CBOH team with Zoe Kernoodle, Josh Barrett, Marcus Saba, Suzanne Killian, most importantly of all, Erin Leach, wherever she's hiding out. There she is down here. We'll recognize her both at the beginning and the end, as she's the engine that makes all of this happen. So thank you, Erin. A round of applause for Erin. I'll keep it brief. Do want to extend my welcome as well on behalf of Kenan-Flagler Business School as well as the CBOH. Thrilled to not only be back in person, but just to continue this event. As I look around the room and recognize just the folks from so many different backgrounds, and this is really the goal of what we're doing here with the CBOH. We know that for meaningful improvement in healthcare, it's going to require a truly interdisciplinary perspective, and that's what we've assembled here. We want to make sure that the voice of business is a part of that discussion, but we know that it's only a part. That if we think about the value transformation that's taken place already, there's major progress that has been made. We can kind of look backwards and celebrate a bunch of individual events, but there's a lot further to go. A lot more of it has still been kind of either or thinking as opposed to both and. How do we really get to a triple aim and think about bringing all of that together? And we have a chance to talk about some important things today. I would hope at some point over the course of the morning you're uncomfortable, that you're challenged, that your perspective kind of gets shaped a little bit. That as we think about improvement in healthcare, it is very much a story of kind of not seeing what we want to believe, but seeing what's really there. And how do we understand kind of where is our mindset moving in the right way, and where are there gaps that either individually or as a system we've missed and they really need attention. And so this first panel is a phenomenal one to get us started. I will say that Dr. Brody, Dr. Samantha Brody is our moderator for this, and one of the most fun panels over COVID that we had was one that she was in the middle of. We had a really healthy kind of behavioral health discussion on some gaps, and there was some pushback and some different perspective between the provider and the payer side of things, which I really appreciated, and I think everybody learned a lot from. But this first panel is Meeting the Moment, Delivering Behavioral and Mental Health Services. Dr. Meltzer Brody is our moderator. I'll let her introduce our panelists as a whole, but she's the Assad Meymandi Distinguished Professor, as well as the chair of our Department of Psychiatry here at UNC, and the director of the UNC Center for Women's Mood Disorders. So, Dr. Meltzer Brody, thank you.
Thank you. It's great to be here, and I'm thrilled to have the conversation today with our distinguished panelists. So I want to start with introductions and offer just a few thoughts before we kick it off. We are at a pivotal moment. I have the honor and privilege to run a very large clinical research training program at UNC, and never before have we faced the challenges we face now in mental health. All of our emergency rooms are packed with patients seeking care. There are inadequate beds, there are inadequate services. The continued inequities in terms of reimbursement, how people can access care, has led to a real crisis. And we have to think of innovative ways forward. So I'm thrilled to have this conversation today, and we are relying on all of you to help craft innovative paths forward and be good partners in this. So we will start by having each of our distinguished panelists introduce themselves and say a few words about their work. So we have Secretary Kody Kinsley with the North Carolina Department of Health and Human Services. We have Danica Patterson with Eleanor Health, and we have Mike Genovese with Acadia Healthcare. So Secretary, if you go ahead and just offer some of your thoughts about your work and your focus of today, we'll have our panelists do that just to kick us off and set the stage.
Great. Thank you so much, Samantha. It's really good to be here. And I'll just first note that no one has sat in the splash zone. During the pandemic, we saw a tripling in reports of stress and anxiety and loneliness. Usually 1 in 3 people would say, or 1 in 9 people in a given week would say, I don't feel so great from a stress perspective. In 2020 and 2021, that went to closer to 1 in 3. What's interesting is that in spite of COVID itself disproportionately impacting older folks, it was actually our youngest individuals that showed those reports. Liquor sales went through the roof while all the bars were closed. Right? 40% increase in opioid overdoses in our ED in the last year after several years of decline. Every indicator that we have, suicides, one of the leading causes of death in young people, over 3,000 kids in North Carolina lost a parent or a caregiver. These are really sobering statistics and trend lines that are not pointing in the right direction. But I think that today, and I'm really looking forward to the conversation, the opportunity for innovation is huge. But also, the opportunity for resource is long overdue. This is not a problem that just skyrocketed that we're going to be able to, it wasn't great up to 2020 and all of a sudden we're just going to make it better. Right. This is a multi-decade, if not a forever problem that we, I think, have a moment to try to put into a different place. And it's going to take a big collective effort, a lot of people to do that. So really looking forward to the conversation and to the questions when we get to that.
Great. Thank you. Good morning. My name is Danica Patterson. I'm excited to be here because I'm a 2-time grad of UNC, so happy to come back and be here this morning. I work for Eleanor Health, and we are a startup organization. We opened our first clinic in September of 2019 in North Carolina. We are currently in 7 states and expanding, and we offer outpatient mental health and substance use disorder treatment. And I'll talk about it over the course of the panel this morning, but there's several things that differentiate us. And I do want to start out by acknowledging one of the things that COVID did was put an absolute bright light on the lack of resources that you've mentioned, Kody, and the dire situation that we're in. And the good thing I think will come out of it is we're not going to stop paying attention to it. We do have a bunch of work to do in this space, which is why my company was started. And so our mission is to help folks impacted by mental health and addiction live amazing lives. And so one of my kind of personal goals is to eradicate stigma that is associated with both of those things, because that is real. That is a huge part of why people overdose, because they're afraid to speak up, or they die by suicide because they're afraid to speak up about the challenges that they're having. So we need to put that front and center and have that conversation and get comfortable with not being comfortable about having that conversation. Only 1 in 10 people with an addiction are actively seeking care. So it's about access, not only acknowledging that it's there, but it's about providing access to care and meeting people where they are and how they want to be cared for. And so Eleanor Health focuses on innovating in the care delivery space. So we focus on being able to demonstrate outcomes. And we have done that because we built a tech platform that allows us to track that longitudinal relationship and see how people are improving over time, see what their triggers are over time, and how do we wrap services around them. We have to innovate on the payment space with our organization because the things we do don't get reimbursed for in a traditional fee-for-service healthcare system. That's a huge problem. We have to find partners that are willing to come to the table and innovate. It's really not radical innovation, but it's innovation because it's forcing inertia to do the healthcare system in a state of inertia to do something different, and pay us for the outcomes that we achieve. So instead of click-based, we want to be paid for outcomes. The third space that I would say that we're innovating in, and I mentioned it, is the tech platform. So we know that the traditional ways of delivering mental health or addiction care aren't necessarily effective. And so we want to be able to offer a virtual platform or a digital platform so that every moment of the day, someone who is faced with mental health or addiction challenges has a tool or a mechanism to deal with it in the moment. So while we're delivering care, they also need a mechanism at those in-between care delivery spaces in order to manage just their day-to-day lives. So I'd love to talk more about that, and really excited about acknowledging that mental health and addiction is something that we need to deal with in the healthcare industry space. And then it's all the things along the way about how we deal with those to bring all of that together and support folks when they need support.
Go ahead.
Hi, everyone. My name is Mike Genovese. I'm the Chief Medical Officer at Acadia Healthcare. We're the largest standalone provider of behavioral health in the United States. We have 243 facilities in 40 states and Puerto Rico. I did not go to UNC, but I am wearing a Tar Heel tie to shamelessly pander to the crowd. I sort of want to echo everything that you guys have said. Danica mentioned only 1 in 10 people struggling with a substance use disorder receives care. And in all of behavioral health, only 1/3 of people with a behavioral health disorder receive any sort of care at all. And if we said that same thing about cardiovascular disease or diabetes, everyone in here would be shocked. And to your point, stigma is part of what gets in the way. Part of what gets in the way is the level of care that patients really need doesn't fit into the model that's always been there. So innovation is critical right now. And historically, I think when we used to talk about innovation in medicine, it would be, well, you no longer have to open up someone's chest to do surgery if they have a blood clot. Now you can thread a catheter up their leg, right? And that would be the innovation. But now the type of innovation we need is the type that makes healthcare work. And to the point that both of you made, COVID served as a catalyst for that. We did things out of necessity, and necessity is the mother of invention, but I don't think it's going away. So some of the things that were, it seems simply, we were using telehealth within the hospital because we would have a COVID unit and we would have to have the therapist or the doctor outside of that unit treating those patients because we recognize we're a critical part of the healthcare system. We couldn't have patients who were acutely suicidal or psychotic clogging up the emergency rooms where patients were going to receive their treatment for COVID. And we also have to talk about different sites of care, like you're talking about. We had spoken earlier about different levels of care, like it shouldn't just be the hospital and then outpatient. There are other levels of care, like partial hospitalization, intensive outpatient that people need. And also patient acquisition and getting to patients, and also recognizing that behavioral health is part of the healthcare system. We've been carved out in so many different ways. A few years ago, the government gave hospitals billions of dollars, meaningful use dollars, to implement electronic health records. Freestanding psychiatry was carved out of that, as if we were not healthcare, right? So things like that became very front and center during the pandemic, and we're working on them now. And to your point, it's not going away. So,
well, thank you for that. So we're going to ask each of the panelists a number of questions and have a thoughtful conversation. And then we're going to save time at the end for your questions. We're going to hold those to the end just so we can make sure that we get through the questions in the program that I think will spark your questions, and then make sure we have time at the end to do that. So Brad, as mentioned, the platform for telemedicine, telepsychiatry, it's not like it suddenly was developed in March of 2020. The fact that for all of us in 2 weeks, we transformed from models which required in-person visits to allowing the payers the opportunity to pay for these visits. Is that politically correct? They had the opportunity to pay for the visits. And then they decided to pay for the visits in March of 2020. It led to this massive transformation. And so the ability to increase access for the patients we serve is sort of unprecedented now in terms of psychiatry and behavioral health care. A few things to note before having our panelists comment. North Carolina, I believe right now, is the 9th most populous state in the country. My understanding is we're second next to Texas in terms of the population that lives in rural areas. So one of the most populated states in terms of number of people living in rural areas. Psychiatry and behavioral health providers, clinicians, tend to not be in rural areas. In fact, the majority of counties in North Carolina do not have a psychiatrist at all, let alone a child psychiatrist. So telepsychiatry has been very transformative in our ability to increase access to care, and digital mental health opportunities are blossoming right, left, and sideways. In fact, my faculty get emails every day asking if you want to go work for a telepsychiatry company somewhere in the country. I'm curious to hear from the panelists. What are your thoughts on this now? Where are we now as 2022 starts to come to a close in terms of how we increase access? The payers are not necessarily excited about increasing access because that causes them to pay more. How do we ensure that we are taking care of the massive mental health crisis we face now using innovative approaches?
I'm happy to jump in. I believe that the original sin, and Dave kind of started on this, is that we carved the mind out of the body, which was silly. All of the data is clear, right? If someone has unmanaged mental illness, managing their diabetes costs more and is not as effective, right? The physical and the mental, if you're not mentally well, you can't manage all the other aspects of your life. At the same time, even if you're getting substance use disorder treatment, but you're not having your dental care taken care of, then it's really hard for you to sustain recovery and get supports there. So we have to kind of put it back together. I had the pleasure of working at the Office of the National Coordinator for Health IT on meaningful use. And part of that was absolutely about thinking about behavioral health as separate, but it was also thinking about psychiatry as a standalone specialty alongside all the other specialists, and the presumption that all specialists make a lot of money and they can all pay for their own EHRs. But the truth is,
that's a really funny story.
I'm good at jokes. But the bottom line is going back to that original sin, is that we're never going to have enough psychiatrists. It's 31 counties in North Carolina do not have a psychiatrist. We're never going to mint enough, the most popular psychiatric fellowship in the country right here, and we're never going to mint enough psychiatrists. And so it takes us back to how do we do things like collaborative care, and what does that look like in bringing people together? Telehealth, obviously, is a phenomenal part of that puzzle, right? A lot of people not only can get access that way, but they can also feel more comfortable. I mean, my mother doesn't mind me sharing this story, but she started her journey in mental health during the pandemic because she finally felt comfortable talking to someone via her phone while sitting in the car, not driving. And so that was like the best thing for her. So it all comes back to, and Danica's point, how do we shift the paradigm to paying for outcomes and paying for quality? I think this is, for me, value-based care is what we have to focus on. Right now, payers are very focused on, widgets, like fee for service and units of care. So telehealth is scary because it does expand access, and there's this belief that if I'm not touching someone, then they may not be getting better, right? But changing that to, you know what, I don't care what you do with your well, I care, but I don't, generally want to micromanage every aspect of your care with your patient and rather focus on the outcome in the end, I think is, frankly, if we're going to sustain telehealth, if we're going to move to collaborative care, all those things fit together, but we have to get to where we're paying for, one of you to be healthy and not just paying for you to have another service.
Yeah, telehealth has to be table stakes. The fear of the payers removing telehealth parity, it keeps me up at night, but we're designing our collaboration and payment models with payers so that it's irrelevant, right? And especially in the mental health and substance use space, we don't need to touch people to make them better. We need to touch their minds to help them and give them the coping mechanisms that they need. And so it needs to be table stakes. It needs to completely be removed from the conversation. It just needs to be a basic assumption. And what it's going to do is, yes, it's going to increase access, but it's going to increase access to the rural areas where they're not getting care and they need it. But a substance use disorder typically accounts for 80% of a person's cost, right? So over the course of a year, 80% of their healthcare costs are directly attributed to their substance use. If the payers would let me take care of the substance use disorder, I'm going to wipe out a significant amount of that cost. And because of the way our model is set up, we're also going to connect them into how they manage other chronic conditions. So to your point, you can't manage diabetes with someone who has alcohol use disorder because of the amount of sugar that they're converting in their body on a daily basis. So the two go hand in hand. You can't separate the head from the body. And actually, I love that analogy because we have separated the head from the body in the healthcare industry from, an integration standpoint and a payment standpoint. And so I think the telehealth access, please let it be here to stay. Let's not do anything to disrupt it. But let's also remove the question mark around, are we still going to pay for it at the same level that we would if someone is in person? I think the other interesting thing that's worth pointing out is prior to COVID, there's a federal law that requires the intake, so the first visit for someone getting into substance use disorder care on the outpatient side had to be done in person. Guess what? On March 13th, when everybody went home, we still did intakes virtually. That federal law was temporarily waived, and we had amazing outcomes. The access and the ability for us to continue taking care of people hopefully made that really terrible number that Kody shared around overdoses lower or less bad than it could have been because we were able to still care for people. I think the other important piece is telehealth allows, again, you only identify as a patient maybe 10% of your life, right? So you're not going to walk around saying, hey, I'm Danica, I'm a patient. You're going to have all these other things that you identify with, but there's always things that you need to be doing every single minute of the day to contribute to what you define as your health and wellness. And so that telehealth platform, that digital platform, enables the ability for us to reach people on an ongoing basis instead of an episodic, periodic basis. So someone should always be working to manage their diabetes. Someone should always be working to manage their recovery. Telehealth allows us to do that. And again, we're trying to create partnerships with payers so that it isn't and you're going to pay us at the same rate you would if people are in person, right? So we're trying to remove that from the conversation. The last thing I'll say about access is we know from our own data, if someone's ready to try to get into recovery, if we can't provide access within 3 days of that request, they're not going to show up. So that telehealth piece is absolutely critical so that the literal transportation issue goes away, but the stigma of if I get in the car and I drive over to this clinic, or I have to take the bus and get over to this clinic, it's too hard. So we don't want to make recovery more difficult than it's already going to be for that individual, or mental health care for that reason, or for that matter. And so that telehealth piece is super, super critical for access because we just have to stop putting barriers in place for people to access care, and this is a glorious way to do it.
So I'm in adamant agreement with both of you with regard to value-based care and with telehealth. I mean, value-based care is essentially incentivizing the provider to render effective and efficient care. And if you're a doctor, it's hard to argue with that. And that's the way most of healthcare has gone. Behavioral health is just a little bit behind. Telehealth is essential going forward. It's not going away. One of my friends is a dermatologist, and she does all telehealth. And she assesses it, and she sees a lesion, and you need a biopsy, then one of her partners does the biopsy in the office. It's just as effective. The other thing I would say with regard to the payers, and this is a slightly different spin on it, but I will just put this out there because we're at a business school. Acadia Healthcare has been engaged in several joint ventures with med-surg systems, large med-surg systems like Henry Ford in Detroit, Geisinger in Pennsylvania, Scripps out in California. And they come to us, and I think really for three reasons. They'll first say, well, we need you to partner with us because on any given night we have 15 boarders in our emergency room, psychiatric patients that we can't place, and we need to clear the emergency room. The second thing that they will say is that you can't make any money in behavioral health, so we need to get that out of there. Interesting conversation to have with them, because then you just start talking to them because, like, okay, well, listen, in your unit, what's your EPOB? And they'll be, EPOB? Yeah, your employees per occupied bed. And then you really haven't thought about how to make money in behavioral health. And it's okay to both make a profit and take care of people and make them better. There's nothing wrong with that. The third thing that comes up frequently is these systems that I just mentioned. They're both hospital systems and the payer, so they have their own, they are the insurer, and they recognize that their cardiac patients and their diabetic patients and all of their patients do better if they have adequate behavioral health care earlier and more effective. So they actually recognize that they will be paying less to the extent that they let us take care of their patients adequately.
Can I just chime back in
Absolutely.
real quick? So Danica made a point that I just want to slam dunk because I think it's so spot on, which is behavioral illnesses and poverty are often co-occurring. Mm-hmm. We've been talking about the rurality aspect of North Carolina and the challenges there, but remembering that telehealth can help overcome bus route issues and people living far away and not having transportation costs, right? 80-ish% of what is health is not health care. It's all the other aspects that drive health. And I think we have to, as we think about whole person, we have to extend to kind of whole situation, whole context to really understand how to drive health. And I think telehealth is another key part of that.
Yeah, I got to jump in real quick. I haven't even said it, but like a huge component of supporting somebody's physical and mental health is around removing social barriers to care. And so the transportation issue is real. Access to stable housing is real. And so that's a part of the comprehensive model that healthcare just doesn't simply pay for today, but it's absolutely critical to get to the outcomes that we want. Again, particularly in the mental health population, but the access game is real, and being able to remove a transportation issue is one huge element to keeping people in care, but then it's also finding those community resources that can address those other social drivers is equally as important.
Well, it's been said there is no health without mental health. And because it seems that everyone has been impacted by a mental health condition of some kind, themselves, a family member, a coworker, the neighbor, a person down the street, at their place of worship, wherever it is. Raise your hand if you know no one with a mental health condition. And raise your hand if you don't know anyone that's been impacted in some way, particularly over the last few years. So either people are being shy, or really the quick data point is that no one does not know anyone. And because the prevalence has increased to this degree, I think that, as Secretary Kinsley said, we have a rare moment to seize the day. When people are in crisis the way they have been, they are desperate, which is what's leading to addiction, overdoses, intentional, unintentional, and suicide. Mental Health America just came out with their 2022 data. North Carolina continues to be ranked about 43 out of 50 states for resources provided for child and adolescent mental health. I think for a state that is this great, that's just an absolute disgrace. And I think all of us have to figure out what we're going to do about it. If we don't invest in the next generation, then, shame on us, and we're all in deep trouble. Because if you have a bottoming out of the mental health of the next generation, then it's not going to bode well for the people of our state being successful and thriving. So with that in mind, one of the things I wrestle with, and I'm really interested to hear your thoughts, working at UNC, a proudly public university and healthcare system, we take care of a very diverse payer mix, from the uninsured to the affluent and everything in between. Many people fall through the cracks. The challenges of the business model of healthcare, when behavioral health is often so poorly reimbursed and we're taking care of a large number of publicly insured patients, is really challenging. So we can talk about innovation, and a lot of the innovation actually requires that you are privately insured or paying yourself, all the fee-for-service private practice, which then requires we get back to policy and the role of government in making sure that we're taking care of our most vulnerable. So don't want to put you on the spot, but I'm going to put you on the spot, Secretary. How do you think about the policy changes needed that in North Carolina that will allow us to take innovative approaches and be able to take care of the population broadly?
So a couple things here. So first, we have been, as Medicaid pays for, right now we have like 2.7 million North Carolinians in the Medicaid program. That's probably got 600,000 more people than usual because of the public health emergency and extending the number of folks on there. But as far as a payer goes and kind of setting some marketplace standards, which is we've tried to use those levers around telehealth in particular. We moved our telehealth policies forward kind of 10 years and 10 days time at the beginning of COVID. And been able to keep it there and try to set those standards. We've also been down this path of moving towards Medicaid managed care, which, there are pros and cons to that environment, and leveraging payers. And we can talk about, we've tried to do it in a very smart way that essentially tries to incentivize, the federal Medicaid, fee-for-service program is very rigid. All the modernization across the country is built on these concepts of waivers. How do you waive outside of cost neutrality to provide different types of services? You can do whatever you want as long as your costs don't go higher than what they would have been in the normal program. Right? And so we have used managed care as a tool to implement those waivers to be able to pay for things like, housing supports and interpersonal safety. North Carolina received the first in the nation, a $650 million pilot program to help support programs, so that way you as an individual could be prescribed a referral to an entity that was going to help you get a mattress or transportation, and Medicaid could pay for that. And over time, we hope to demonstrate that creates a lot of value for people. The system, I don't believe over the long run we will see it supplant the necessity of WIC and SNAP and foundational programs that help support people. And I think this is a huge thing for all my beloved data nerds. We have got to use better data. Right now, I cannot tell, this was true a month ago. I could not tell you how many people were on Medicaid but did not take advantage of food stamps or WIC, our foundational food programs. We had been very focused in kind of modernizing all the extra that we weren't doing the basics. And we now know that, and it's an alarming number that I'm not going to publicly release this minute. So we are working on improving that. So that's kind of first thing, kind of managed care kind of as an opportunity. But the second part of that is setting the stage to encourage other providers. I loved Mike's point about if you haven't really thought about how to make money, I like to say no margin, no mission. If you haven't thought about a way to make money in behavioral health, it's probably because you just haven't really tried. This is, again, back to that original sin, just the legacy of not actually thinking about it. So I think, again, using our Medicaid program and our regulatory rules to try to set different standards that encourages that, and pushing harder and harder and harder towards value, I think drives, we've seen so many healthcare systems apply to operate psychiatric beds in the last few years because all of a sudden they realize that, guess what, they're owning the problem in their ED, and they can't just think about that as a problem thrust upon them. They have to think about is that's a cost center that I have to address, and sometimes you have to invest money to make money. And owning the problem across the board matters. So there's an accountability there and a transparency issue. The last thing I'll just say, and this is a particularly North Carolina issue, we have 1.2 million people in this state without health insurance. We're one of about 10 states that have not expanded Medicaid. It's just silly pants. And, just the numbers here, right? So if we were to do Medicaid expansion and we were to do this thing called HASP that helps and give hospitals extra funding for their margins, it would draw down $8 billion a year into North Carolina at no cost to the state taxpayer. But wait, there's more. The federal government has said there's a $1.5 billion signing bonus if we do that now. Now, I like to go over this from two ways. One is think about where we would be as a state, not 43rd, if 10 years ago we had expanded Medicaid. And we would have drawn down, $40 to $50 billion before COVID. And people had a primary care provider and their chronic care conditions were in check and a much different situation was in play, right? And my point to the General Assembly is, look, as the board of directors for the state of North Carolina, I'm bringing you a deal. And that deal is $8 billion at no cost to you. And if you don't say yes to that deal, you're violating your fiduciary responsibility. And we have got to move forward to do that because frankly, we can make all, and most of these people are working. They work in childcare jobs. And guess what? If these childcare centers don't stay open, employers don't have an opportunity to have their workers come to work. So it's a super smart investment. And in the end, we are not, there's a lot of things that we are doing to modernize and whatever, but until we fill that gap, it is just this big, big gap where we will never be able to efficiently move forward from a policy perspective.
Thank you, Secretary. And then would love for the two of you to offer your thoughts in this space and what that means from your respective perspectives.
Yeah, so Medicaid expansion, check. One of the things that we said as an organization very quickly, in spite of North Carolina being our first market, we said we would not go into another market that was not a Medicaid expansion state because we want to lean into the Medicaid population. But we want to be agnostic of payer, right? So we want to have the ability to lean in and support Medicaid. We want to have the ability to identify people without insurance who need help and get them signed up for Medicaid. Get them on their feet, get them a stable job, and then guess what? They have access to employer-based coverage, right? We also are providing care to the commercial population and the Medicare population. And so we could fee-for-service the heck out of the payers and do things like bill for the expensive labs or make folks come to a therapy visit every week or their medical visit every week. And we could do things like that, but it doesn't change the outcomes. And then there's all the other stuff I mentioned earlier, peer coaches or to support folks in between visits or nursing care management to do care coordination. So we want to make sure that we can treat the mental health and addiction while the primary care provider or specialist can provide support for the chronic conditions, right, on that medical side. So integrating all of that is really important. I think from a payment perspective, what we have then had to do is go to payers and say, step out of your comfort zone, let us give you the outcomes that you need. So we're going to improve quality, we're going to reduce total cost of care, and you have to pay us to do that up front, and we'll put our fees at risk if we don't do that. So that's it shouldn't be radical innovation. We should be doing that all over the place. We need Medicaid expansion to be able to do that with the Medicaid population. The commercial payers are getting there. They're very interested and eager now, thank goodness, to start leaning more into the mental health space and the behavioral health space. So the providers need the data in order to identify what patient population they need to go after. And then once they've identified that, what is it that patient population needs to address in order to get better? And then the payer needs to lean in to be able and willing to pay for it. So it's kind of a deal. I mean, the way we pitch it to the payer is, you could call this an experiment, you could call this a pilot, or you could call this like the permanent way that you want to pay for medicine. So let's attach payment to outcomes. That is a wild concept. And then let us figure out how to do the work. And so don't get caught up, payer, in, oh, well, that's not a CPT code billable event, so we can't figure out how to pay for it. We have to figure out how to get around that. And we're not doing this, but I'd love for us to figure out how to get there. And, true management of somebody's health is going into the home and understanding what is going on in their environment. So for somebody who has diabetes and you go into their environment and they have 20-year-old carpet and no air conditioning unit, guess what? They're going to have an asthma exacerbation all of the time, and they're always going to be in the ER, and we can't figure out why medication isn't fixing it. So if we go and rip out the carpet and give the guy, a window unit at worst, we're going to reduce those exacerbations and we're going to reduce the total cost of care, but there's no CPT billable code for that window unit. So if we can remove that layer of complexity and allow providers to identify what change needs to occur from health care or the health and wellness of an individual, let us figure out how to pay for that, and then we'll put our fees at risk. If that person still exacerbates and goes back to the ED, the emergency room, then take the fees back. And that's kind of what we're willing to do. And it's scary. I mean, I've been in fee-for-service for a really long time, and finally woke up one day and said, we can figure out how to do this value-based thing, and we need to do it in a meaningful way. And so, again, I mentioned it earlier, we're not going to the radical innovation. We're not paying for the window units. We should be, but if we can incrementally demonstrate the value along the way and get everybody to lean in together and understand how the outcomes are really going to make the difference, it'll be a little bit easier.
Thanks. Go ahead, Mike.
I'm going to try to be brief, be sensitive to the time. I'm going to pan out a little bit to federal policy, because I think when you're in the work that we do, behavioral health's been in the shadows for such a long time. We know things we assume other people know, and we assume that the staffers on the Hill know, and it turns out that they don't. And so we're dealing with them now, and I think the essence of what it is kind of tying up what a lot of us up here were just saying. There's a bill right now that's come out of Ways and Means. I think they call it the Psychiatric Facility Improvement Act. I won't call it that because that's not what it would accomplish. But they want more data, right? And we want more data. Like, cardiologists get to get cardiac enzymes and EKGs and all sorts of things. And Medicare payment wants more data. But what they're trying to thrust upon us is, okay, well, does the patient have bed sores? Does the patient have congestive heart failure? That's not relevant to an inpatient psychiatric facility. Let us give you the data. Let us give you the PHQ-9 and measurement of their depression. Let us give you their GAD. Let's work together so you're getting the data that's actually relevant and will improve outcomes. And then I'll tie it back, because I'll say, and how we'd be able to get that to you is if you give us some money for an EHR, and then we could collect it like that, and then it's a win-win for both of us.
Great. That's great. Well, we have time for one more question, and then we'll open it up to all of you. And this last question we'll have to keep pretty tight so we have room for discussion. The last question really is about the business model. We've been talking some about that, but this is the Business of Healthcare Conference, so we really want to focus on this. A number of the innovative approaches and tech approaches, many of them have had a lot of venture capital investment to get going. There's been this plethora of startups of all different flavors. Curious to hear your thoughts around what's your sense of the business fundamentals underlying this innovation and these new businesses? What are sustainable? What are going to be a flash in the pan? And how do we think about health equity as we think about these models? So, Mike, if you wanted to start.
Sure. Yeah. You've seen everything. So you've seen some things come and go in the course of a week, and you've seen some things that are sustainable and are going to work. And can keep this really brief. The people who work in behavioral health care tend to be there for a reason. So there are really smart CFOs and COOs and CEOs in our company that could be working anywhere, but it's almost like a calling to behavioral health. So I want to keep it short. It's the right person in the right place for the right reasons. So to the extent that behavioral health is a calling for you, or healthcare is a calling for you, don't think of it as a barrier to business success. There are tons of innovations, and neuroscience has progressed more than I think any other field of medicine in the past 10 years. So take advantage of that.
Yeah, I'll be quick because I have a hard time doing that. So we're equity backed, and it's the promise of what we're going to bring. So the resources that we've been supported for are focused on being able to tell the story. And so what we had to do first was prove that we have the ability to generate the outcomes, and then we actually had to show those outcomes. And so building that longitudinal view using the data is really important. So showing that there's an improvement in depression and showing there's an improvement in anxiety then creates that benefit for all other things, a reduction in high cost utilization. So super important from the data perspective. So that's one big commitment. To be completely transparent, there is an ROI expectation, and there should be. And so, again, it's if we can focus on delivering the outcomes and demonstrating that we're delivering those outcomes, the cost perspective kind of covers itself. And so very metrics driven, very business oriented, and we were co-founded by two women, so a black woman who's a psychiatrist and boarded in addiction medicine, and then someone who's run a couple of giant Medicaid plans like in the state of Massachusetts. And so having that business acumen and that clinical quality acumen was like the perfect match in order for us to kind of set the stage for finding investors. But then the demonstration of what we've been able to accomplish, demonstrating what we've been able to accomplish is another big thing. So I think there's going to be, obviously with the State of the Union, there'll probably be a slowdown in investment, but I think there's going to be a huge ramp up and a big sustainable play in the mental health space from venture capital back.
I'll just say quickly that, we have got to be so much more aggressive. I think we've talked a lot about value-based care and trying to get more people insured and the return on investment of doing those things, but this is a huge problem for our state and for our country. And, you're talking about more data, Mike, and I appreciated that so much because we zoom in too much on these little data elements. The data that I'm interested in is how many people with untreated mental illness end up in jail or prison at a cost to the state. How many people with untreated mental illness or substance use disorder end up homeless or end up leveraging other systems. Like when we really think about total cost of care, or rather the total cost of doing nothing, like, I don't believe from a social ailment perspective there is a more valuable investment for the people of the country than in behavioral health. And I think what that warrants is a moonshot-like, policy effort where, just like Operation Warp Speed with the vaccines, we were willing to pay no matter what we got so that businesses could try to do whatever they needed to do to be successful. And we limited risk in a huge way, and we did this huge moonshot, and that's what we have to do. I think policy, we've got to think of a different paradigm here for government and business to work together, where maybe government is leveraging its, frankly, unparalleled resources compared to any other venture capitalist investor and say, look, we're going to back a huge effort at risk, and we're going to have equity. Historically, our government has not done that in a good job, right? Like, the United States government was an $8 billion financial backer for Tesla. And the terms were that if Tesla failed, they'd have to pay us a little bit of money, but if they succeeded, they just have to pay us back the $8 billion at minimal interest. What a bad deal for the American people, right? Like, we should own half a Tesla. And that we could go a different path there. But stop tweeting that. But my point is simply that we could really reimagine how the government, recognizing the overall broad impacts here could invest in this in such a different way and be a partner at a broad scale and really transform it. We're not going to break out of this unless we do something huge, and I think we have to.
It's time to think big. So we'd love to hear your questions as you're all thinking big, and we have time for a few. So go ahead and raise your hand, and we'll get some help with the mic. Thoughts, questions? Anyone have the solutions all figured out? Brave people.
Farthest back as possible. So it seems like telehealth is sort of seen as this beacon of light. It's going to increase access, but I've seen studies that utilization has increased in urban areas, but not so much in rural areas. And I was wondering if that's what you've seen and why you think that might be.
I've seen the opposite. So we have 11 locations in North Carolina. And so we have a physical footprint, so we can meet people if they want to come in person. But I've got folks that are actively in care that are in Elizabeth City, Hendersonville, Spruce Pine. I mean, these are super rural areas and otherwise would not be accessing care at all. And so we have our data team created a map, and they've put a dot for the home address of every one of our members on a map. And so I can pull up North Carolina or all 7 of our states and see, yes, there are clusters in the more populated areas. But we've been using like a hub and spoke type of approach so that, folks in Fayetteville can come into that clinic. But again, I've got the Elizabeth City folks that are attached to, a Wilmington clinic or a Fayetteville clinic. They otherwise would not be accessing care. And so that fully virtual model has really supported that in a meaningful way, particularly in our own state. We also have the luxury of our VP of Medical Operations is Dr. Steve North. He's from rural North Carolina. He was trying to be a big pioneer in the state around virtual prior to COVID. And so we kind of stole that secret sauce so that we could put that in play for us, and we were allowed to flip over much faster overnight.
One of the things that we have to consider is a lot of the rural areas haven't had broadband internet access in North Carolina, which would be a major barrier. Other barriers, any other data you wanted to share? Okay, yeah. I think you have to have internet, and in rural areas in North Carolina, that's been a barrier. I would certainly say our data at UNC would support that there's been a great uptick in rural areas and engaging in this in places that actually had internet access. So one of the challenges is how do you either get internet access or you designate a site that has internet access for people to get to that's local. There's another question up there, I think. Oh, good. You're ready to go? Okay.
Can I ask a follow-up to that at the same time? So, and I think this is along that same thing, exactly what you were saying about broadband internet, is we've also seen studies that issue is also furthering an equity gap as well, specifically for that. So I'm curious, especially this might be for Secretary, what's being done at a state level to kind of help that process of gaining broadband access, as well as what you talked about as well, the mental health providers in the rural areas, because we're also looking at these digital engagement platforms and things that our rural populations may not be able to be comfortable using and taking up, just from a health literacy standpoint as well.
Yeah, I should know the number exactly, but I don't. So I'm just going to say that the governor has put $1 gajillion into expanding broadband, and I'd encourage everyone. We have a whole effort that's a mix between, we've huge RFP for big companies to come in. I think it's close to $1 billion. It's a lot of money using the ARPA dollars to invest in broadband and 5G expansion across the state in a number of ways. But to your point, at the same time, we've got to do digital literacy and support people in actually knowing how to access. I'm my parents' technology support person, but like not everybody has that, right? And I don't want everybody calling me. And so, you know, we partnered through COVID with a number of community-based organizations to expand access around information on vaccines and testing, how to leverage telehealth resources available to folks to get access to treatment. I think we have to think about how do we continue to pioneer that. I also think this is a great opportunity for our public library infrastructure. I mean, this is one of those spaces where people can go and use technology, but there's also a place to kind of scale up support and people being able to take that on.
All right, well, we're at 9:59, so to our organizers, one more question or one quick question. Did you have a question there? Okay. Do you want to shout it out so we don't have to run? Go ahead.
Yeah, we're talking a lot about mental health access, but what we have to remember is that primary care access has to happen also. Screenings for depression, anxiety, substance use disorder are happening first in primary care. So we need to improve access to primary care in these rural areas as well. Thinking about non-physician providers, so improving access, that might be something else we could consider as well.
Can I validate you?
Yes.
Yeah, so my wife is a family practice